Regional Odontodysplasia by R.J. Rhodes and John Hinds. In this presentation, we will cover the definition and clinical findings of regional odontodysplasia, the radiographic findings, the differential interpretation, treatment, the key points, and finally the resources that were used. Definition and demographics. Regional odontodysplasia, which can be abbreviated to RO, is a rare developmental defect that affects both the primary and permanent dentition. These developmental defects affect both the ectodermal and mesodermal tissues of the patient and is non-hereditary. RO is generally a unilateral lesion that affects one quadrant of the mouth and does not cross the midline. It is seen in both the maxilla and mandible, but the maxilla has a higher prevalence for this defect in an estimated 2-to-1 ratio. In regards to demographics, RO is a rare defect with an occurrence of less than 1 in 1 million. It affects both primary and permanent dentition and has no prevalence to a specific race. It has been shown to be more common in females than in males with a slight ratio of 1.4 to 1. In the images below, they show the occlusal view of both the maxillary and mandibular arches. Only the primary teeth in quadrant 2 is affected. The defect does not cross the midline and the mandibular arch is unaffected. Causes and symptoms. There is no known etiology for RO, but there have been theories to suggest causes such as trauma, low blood supply to the area of the teeth, drugs, nutrition, infections, or radiation. Patients with RO present with symptoms such as delayed development of primary and permanent teeth, failure of teeth to erupt, and poor aesthetics. Other complications reported from patients are swelling or abscesses of the gingiva and periapical infections.
Now we will talk about clinical signs. This defect has many clinical signs including short roots, wide pulp chambers, open apices, a yellow-brown tooth discoloration, reduced radiopacity, and thin enamel and dentin walls that are hard to differentiate from one another. The thin enamel and dentin give the teeth a faded appearance on radiographs, which characterizes RO with the term of ghost teeth. Radiographic findings. Location. Found in one quadrant and does not cross the midline. More commonly found in the maxilla. The edge is well defined. Shape. Tooth-like appearance with large pulp chambers and pulp canals, short roots, and open apices. Enamel and dentin are thin and it is difficult to discriminate between, frequently described as ghost teeth. Internal structure. Radiolucent pulp chambers and root canals, reduced radiopacity of enamel and dentin. Other, none. However, due to the condition, there may be a higher risk of caries with abscesses and internal/external resorption. Number. Associated with teeth in one quadrant. Size. No determinate size affects teeth of one quadrant differently.
Differential interpretation. Regional odontodysplasia may present findings similar to dental tooth formation anomalies such as amelogenesis imperfecta, dentin dysplasia, and dentogenesis imperfecta. With amelogenesis imperfecta, patients have thin or absent enamel, which will cause a decreased radiopacity. It will also cause the teeth to have a characteristic yellow-brown color and open contacts. These characteristics are similar to RO, however only the enamel is affected and the dentin and pulp chambers are generally normal. For dentin dysplasia, it is also a hereditary condition, and then there's two main types, type 1 affecting radicular dentin and type 2 affecting coronal dentin. Along with the dentin affected, type 1 dentin dysplasia presents with short and blunted roots that can resemble RO. However, pulp chambers are obliterated. With type 2, pulp chambers are generally very large in the coronal portion of the teeth. Both types present with bluish colored teeth. In regards to dentogenesis imperfecta, the genetic anomaly is similar to dentin dysplasia and consists of 3 types. The dentin affected may cause enamel to fracture off, and the roots are generally shortened. The color of the teeth may be bluish or yellow-brown. Type 1 and 2 have obliterated pulp chambers, and type 3 has the large pulp chambers. Dentogenesis imperfecta is also characterized with bulbous crowns, which is not found in RO. The final differential interpretation is regional odontodysplasia itself. Compared to amelogenesis imperfecta, dentin dysplasia, and dentogenesis imperfecta, RO is a non-hereditary defect and affects only a single quadrant of the mouth. The other three hereditary conditions, however, generally affect the whole dentition and are not localized.
Now on to treatment. The primary goal of treatment for regional odontodysplasia is to restore function and aesthetics. Each patient should be looked at on a case-to-case basis to determine the best type of treatment. For patients with teeth that have a good prognosis, the preferred treatment is to retain the teeth and to place composite veneers or crowns. This type of treatment will improve function by restoring contacts between the teeth and establishing occlusion to the opposing dentition. It also improves aesthetics of the teeth and allows the patient to conserve tooth and bone structure. If teeth are not able to be retained, then the next treatment option for regional odontodysplasia is extraction of the teeth. It is important to try to conserve alveolar bone in order to have a larger bone height. This will provide a better outcome for placement of a fixed or removable prosthesis in the future. With more bone conserved, it also allows for the option of placing an implant in the patient. The last treatment option is to elect for no treatment. If the prognosis of the teeth are good and the patient does not mind the associated loss of function and aesthetics, they have the option to defer treatment. To wrap things up, I'll go over a couple key points. Patients with regional odontodysplasia have characteristic findings of delayed development of primary and permanent dentition, along with possible failure of eruption of teeth. This defect only occurs in a single quadrant and does not cross the midline of either the maxilla or mandible. Teeth that have erupted are generally of poor aesthetics due to thin enamel and dentin, making the teeth appear to have a yellow to brown discoloration. Radiographically, RO commonly presents with decreased radiopacity of enamel and dentin, making the quadrant affected appear to have a ghost look. Along with this, radiographs show teeth with short roots, open apices with large pulp chambers and pulp horns. Treatment for patients is focused on restoring function and aesthetics. When prognosis is good for the teeth, the best treatment is to place veneers or crowns. This will give the teeth the proper strength and color to restore normal tooth anatomy, speech, and eating. When prognosis is not favorable, extractions will be done with the emphasis in preserving the alveolar bone for a prosthesis or implants.
Here's our reference list for our topic of regional odontodysplasia, and we direct you to these resources to learn more about the topic. Finally, here is our image citation list for the images that were used throughout the presentation.